Arup for giving me this opportunity to participate in this instruction course. As already been said, every cataract surgeon who does a very good job, he'll be just waiting for the patient to appreciate the results. But in the contrary, patient sees everything blurred, so he's not happy. Surgeon gets annoyed and then he takes a close look at the cornea and then to his dismay, he finds that something he has missed during pre-operative examination. So there are certain conditions where they are very subtle. If you take proper precaution in the beginning, probably the outcome is going to be perfect. So it will be good. So I'll just go through a few examples to substantiate this and then let's see. So here is a middle-aged, about 48 years old lady who had a clear cornea. It was grade 2 sclerosis, PAC, only post-subcapsular cataract was there, fundus and everything was normal. But the surgery went on very well. Next day, the first post-op day, patient came back with corneal edema, which was not expected in that case. And then when I went back and looked at the other eye, and high magnification rectal illumination, I could see these guttae. So probably what I missed in this case was Fuchs endothelial dystrophy, which is not very uncommon. So this is a genetic disorder, it's a type of dystrophy which affects endothelium bilaterally. And initially, if we see, you can see under the high magnification slit lamp, there is a lot of guttae. But one important examination that is to be performed is specular microscopy, which saves a day. If there are a few guttae, and the endothelial count is good, probably the surgical outcome is going to be good. Otherwise, if you see a lot of guttae and then this progresses, and the patient may end up with a corneal edema post-operatively. So pre-op evaluation is very, very important. One has to see what is the status of the cornea, whether this edema is more. Our patient says morning his vision is good, and then as the day progresses, vision is bad. As day progresses, vision comes down. So that means probably the endothelium is decompensating. And then one also should look at cataract, whether it's really dense or not, and then take a decision whether he should go with a combined surgery or a cataract surgery alone. More important than anything else is the counseling part. Unless we prepare the patient and he should know what to expect after the surgery, he should also know that there is a possibility of the corneal transplantation either at the same time or later on in life. So counseling is very important. And this is one condition where the cataract needs to be operated at the earliest, in the sense that don't allow the cataract to become too dense, the nuclear sclerosis to increase. So earlier cataract intervention is advisable, and it is advisable to keep the inflammation in the check, even pre-operative steroids in the form of either ointment or the difluprednate about 1 or 2 days prior. It keeps the inflammation in the check on the immediate post-op day. And the surgical strategy should be such that we should use, of course, it goes without saying that we have to use good viscoelastic, like something like Viscoat with chondroitin sulfate and sodium hyaluronate. And then the surgery should be with low flow, that is the BS, and we should use the chilled BASS plus as far as possible. And then it should be in the bag and a direct chop. So that the surgical time is reduced, the amount of phaco energy that we use is also reduced. And then for IOL power calculation, one should use the topography. Suppose there is in the setting of microcystic edema, one should reduce the corneal edema and then use the K reading from this. And then one should be able to use power modulation, micro phaco with maybe the transverse or torsional phaco would be better. And now in this setting, probably now the femtocataract scores over this in this matter because the capsular axis and the nuclear fragmentation is done without opening the eye. So thereby the power usage will be cut down, maybe up to 50%. And the IOL that we are going to choose, multifocal lenses, has already been mentioned by Dr. Arup, is contraindicated and one should not use. Then aspheric monofocal single-piece lens is advisable. Any toric lens or the accommodative lenses, again, because they depend upon the good visual acuity for the patient to...
Satya, I'll just interrupt you at this stage. Yeah. David, in a patient who doesn't have a frank Fuchs in a cornea guttata, it's for David, patients with a cornea guttata, and there is a lot of pigments and there's loss of hexagonality and good findings are seen. Would you be using a multifocal lens for those patients?
Yeah, I think I'm very conservative with multifocals. If you realize that there is a reduction in contrast, very unforgiving of any additional incremental loss. So I think Fuchs, even a sign of it, you have to really strongly consider the fact that it will likely worsen over time. And so when I see Fuchs, I really go away from the multifocals.
Even cornea gutta also, we would not be using a multifocal lens.
Yeah, I think you can weigh if it's a really older person, just a few guttata, they're probably not going to have a clinical disease. But you're trying to predict not just now, 2 months after surgery, will they be happy, but 5 years, 8 years down the line, and that's where you have to be careful.
Thanks. And then as far as IOL power is concerned, usually if patient undergoes DSEC later on, there will be a hyperopic shift about the 2 diopters. So it's always better to err on the side of overcorrection, maybe up to 1 to 1.25 diopters of lens power. And then of course there is always it's a debatable point whether it should be a combined surgery or it has to be a sequential surgery, either combining DSEC with cataract extraction, triple procedure or not. There are advantages and disadvantages of both the sides, but again there are a few criteria. Suppose if the central corneal thickness is more than 640 microns, then it is better to combine the surgery. If it is less than 640 microns, then probably one can go ahead with the DSEC surgery. If patient has no cataract but only the corneal problem, then go ahead with only the corneal surgery and then cataract can be taken up later on. If patient is younger, say less than 40 years, probably his chances of developing cataract is much slower. He will develop maybe after 10 years. I think better to go ahead only with the corneal surgery. So like this. And the post-op management, always it is better to keep the inflammation under check and then continue the steroids for a little longer period. Also the intraocular pressure. One should avoid dorzolamide because that is going to increase the decomposition of the existing endothelial cells.
Satya, I just would like you to, are you presenting anything on pterygium?
Pterygium, yes sir, there's one case.
Yeah. So I'd like to ask you, a patient with pterygium, different grades of pterygium, and the patient asks for a multifocal lens. What would be your advice to the patient?
Yes sir. Only thing is once we remove the pterygium, we have to wait for the corneal surface to stabilize. Once you know that there are no further changes taking place and there is no astigmatism, or even if the astigmatism, maybe you can combine with the toric multifocal. But one case, for almost 6 months the changes went on. In fact, I ended up with 5 diopters of astigmatism. I'm going to present that case. So I would prefer to avoid or wait for the corneal changes to stabilize topographically.
Yeah. So remove the pterygium and wait for the astigmatism to stabilize,
yes,
corneal surface to stabilize, and then go for an advanced technology lens.
Exactly.
David, would you comment anything on this?
I again would be really careful. I think that's exactly the right approach. You have to treat it first. When you do a multifocal and you assess risk factors, you always have to say, what's my backup step? So if the person has a lot of astigmatism, I may not get it all with astigmatic keratotomy, but at least I can do keratofractive surgery later. But if they have any irregular astigmatism at all, there really isn't a next step other than a rigid contact lens. So I'm very conservative if there's imperfect, if there's any ocular pathology at all.
Thanks. So another case where surgery went on very well, it was a very simple cataract, but again patient's vision was not good. It was not going beyond 6/18. When I did the retinoscopy, I could see the scissors reflex, and then topography showed a form for keratoconus. This is one condition which we'll have to keep in mind. And so topography, whenever you feel that patient has got a little steeper cornea and astigmatism, and it's better to rule out. The lower one is the PMD, pellucid marginal degeneration, which again poses with astigmatism. That again one should keep in mind. Salginal nodular degeneration is one condition where we have these nodules which, if they are in the periphery and center looks clear, especially in this case, surgery went on very well, but patient was not happy because on topography I could see a lot of aberrations in the center. The central part was highly aberrated. So, salginal nodular degeneration, you can have the central scarring, thin scar, which if we miss, probably the results are going to be bad. So, Then another case where surgery went on very well. This was not mine, referred to me by someone else. But on retinal examination, I could make out these fine fingerprint-like lesions on the cornea. This was a case of epithelial basement membrane dystrophy, which again it needs to be treated as per the lines, and then one should always keep this in mind whenever we do a cataract surgery. This is another uneventful surgery. Patient was doing well. He did well in the early post-operative period. Later on came back with multiple punctate erosions on the cornea, which was a case of keratitis medicamentosa. So one should always keep this in mind and change the offending agent in case if you come across something like this. And then one pterygium case, one case with the pterygium, as I said, patient, it went on regressing up to 16 weeks. I could make out 4.5 diameters of cylinder where I had implanted the toric multifocal lens. And then to just to add a fine opacity in the center against a mature cataract, probably we are likely to miss, and that may again cause a problem. So as already been mentioned, cornea contributes in a major way to the refraction of the eye. So one should always keep a watch on the early subtle corneal lesions and then go with the surgery. Thank you for patient listening.